All right, hello everyone, and thank you so much for the kind invitation. Ett jättestort tack för inbjudan. Det är jättetrevligt att vara här i Stockholm. Kiitos kutsusta. So, my name is Jani Mononen, and I come from Helsinki University Hospital. I work there as an emergency physician. I'm the head of the department, or as I like to say, the janitor. So, a little bit about my presentation. I will tell you a little bit about our home base. You need to sort of know the context. Then I was asked to give a talk about our implementation process of the emergency physician-led intubation. I'll go through that, and then a couple of words of our standard operating procedure. So how do we do it at our place? I don't have any conflicts of interest to declare. Here you can see my home base, Helsinki University Hospital. Perhaps part of you know that Finland is we have two national languages, Finnish and Swedish, and Meilahti heter Meilans på svenska. It's a very traditional place, big university hospital, kind of slow to adopt new things. That's the scenario. We take care, or our area is located on the southern coast of Finland. Our main responsibility is a population of 1.7 million people that we take care of tertiary care for. There are, you see the little red dots there that are other hospitals, and the big red dot in Helsinki is our place. Then we have special responsibility area, a bit wider area, and if we take that into account, then our population is about 2.2 million. So our place, we have adult patients, 16 years or older. There's nearby separate EDs for obstetrics and gynecology and pediatrics, and Children's Hospital. Like I said, we have quite a big focus on tertiary care, so we have huge intensive care units and advanced level surgery, heart surgery, interventional radiology 24/7, organ transplantations, the whole shit. We are a trauma center, the biggest one in Finland, but we also are a community hospital. And the vast majority of our ED patients are quite regular ED patients with quite regular complaints. So the case mix is very wide. A little bit of our specialty is that our clinic also has or operates other units beside the emergency department. So we do have quite a large 18-bed intermediate care unit where we have intubated, ventilated patients. We use vasoactive inotropics, and we have intermittent hemodialysis, not continuous renal replacement therapy. Then we also have 22-bed short stay unit, just to give you a bigger picture of the place. Every specialty, of course, in the hospital, and some of the doctors from the specialties, or we still have a lot of doctors from the specialties working in the ED with us. So there are emergency physicians, then there are doctors coming from the specialties. We sort of work side by side, depending on the specialty. Numbers, of course, always good to know. So 100,000 visits per year, 250, 300 a day. I don't know if that's that's a lot for you or a small place, but among the 3 biggest in Finland, if we look at the numbers. About 60 beds, so a lot of beds, and also special kind of trauma care, so a hybrid theatre in the ED. A lot of people working there, 200 nurses, at the moment about 15 specialist doctors, 20 plus juniors, and a lot of doctors doing shifts from other clinics. But then, to the subject, implementing emergency physician-led intubation or airway management, the ED. When we look back to year 2020, so 6 years back, maybe 2019, so 6-7 years back, we didn't have this. We have always had a sort of high resource environment, so we have had the luxury of having a anesthesiologist. So one anesthesiologist in the ED 24/7. Might have been a junior doctor, or often is a junior doctor, or was a junior doctor. But anyway, someone from the anesthesia clinic working in the ED, taking care of the airway management, central lines, taking part to critical care, so on. And back then, majority of our doctors, we were much fewer. We didn't have that many specialists then. Majority of us were other than emergency physicians. Where we are now, 26, about 50% of the former anesthesia coverage is taken care of by emergency physicians. So our specialists and our experienced trainees, so maybe doing their last year in the specializing program, and the emergency physician-led airway management and critical care are part of our daily routine. 6 years. How did we get there? But more importantly, why did we make the decision to want to get there or here? I tried to play with the artificial intelligence. My partner is a graphic designer, and he would be horrified of this picture. But anyways, there's a process, some kind of visualization of a strategic process. So you might want to think about when you want to change things. So first of all, you need to know where you are now. Then you have to think, are you happy with it or not? And if not happy, you have to visualize. You have to have a picture of your goal, where to set the goal. Then start to think about the strategic choices you have to make to get there. What do you have to do, and what do you have to stop doing? And then, of course, the hard part of implementing it. So back then, 6-7 years ago, we thought that we're not happy, because we thought we had ownership in the emergency department, partly. Many of the processes were sort of owned by us, but still there was this lacking in some areas, namely, for example, the airway management and the critical care involvedness. And we wanted to widen this ownership or own the whole place. we also saw the need for that in the system, because I don't know about you, but in Finland, in the Finnish system, the traditional specialties, they are pulling away from the emergency department. So we thought, to have a sustainable way of running things in 10 years, in 15 years, we have to start building our own quite strong system to take care of the place when the surgeons, when the anesthesiologists, when the internists are gone, because they are going to be gone. And our goal was set to build a skilled team of emergency physicians capable of taking responsibility for the care of the critically ill patients in the ED, including airway management. We didn't write it down. We didn't have a formal plan to do it in writing, but this was the thought. Why? I mentioned a couple of things why, but although it sounds luxurious to have 24/7 anesthesia coverage in the ED, it wasn't that happy a place, because the people doing the job were oftentimes junior doctors. They were working in a strange or unfamiliar environment. They didn't know the team. They didn't know the equipment. So although you could say, or someone in the anesthesia clinic would say that the quality was there, they had the coverage, but it really wasn't. The quality wasn't there. There was a lot of variability between operators or doctors, and oftentimes we had a standard a small one, but although some kind of standard operating procedure back then also, but the compliance to our instructions was poor. So the anesthesia people, they just wanted to do it their way. Then we also discovered or saw that the problem was that if we had a critically ill patient, the anesthesiologist was sort of consultant, was giving advice, doing this and doing that, maybe intubating and setting a central line, etc., but wasn't taking the responsibility for the whole situation of the patient or the whole patient. So there was a problem of lacking comprehensive responsibility of the patient. If we think of resource allocation, it really also doesn't make sense to put in one guy or girl to the emergency department only doing intubations and central lines and sort of this and that of critical care, but not doing anything else. If there wasn't anyone to be intubated, or anyone didn't need a central line or arterial cannula or whatever, they were sleeping, of course, during the night. So we thought that if we would have more of a multitasking person doing these things, it would be better for our resource allocation. We also wanted to, or saw that there was a lacking understanding of the patient conditions as a whole. As anyone here in the audience who intubates knows, with this, with our new equipment and our techniques, it's quite rare to have a anatomically really difficult airway. to get the visualization is nowadays quite easy, oftentimes. But it's really common that we have a physiologically difficult airway, meaning that the patient is shocky, the patient is in respiratory failure, the patient is in extremis. And if you put an anesthesia junior to induce anesthesia for a shocky patient, do you know what happens? It's a condition called PEA. So it really wasn't the ideal situation. So we wanted to create a situation, enable the management of the airway by the person that knows the patient and knows where he or she is doing the job and knows the team. Because people function better in familiar environment and when working with familiar people, as we all know. Then we also saw that if we would do this ourselves, it would enable us to have more practice together. So the team that does the work has a lot of opportunities to practice together in everyday work and in simulations as well. More difficult to organize when the doctors are coming from a different clinic. More wise, of course, it's a meaningful job description for an emergency physician to take care of critically ill people. We have to think about careers and sustainability and meaningful job descriptions for our people, so that they have the energy to do it for decades. We saw that we were missing valuable teaching opportunities for our trainees, because the anesthesia, they weren't that happy or that comfortable in teaching our trainees. So we wanted to sort of take the responsibility and get there and get the teaching opportunities as well. I told you about, or talked already about, the resource allocation. And so then we were anyway doing a bit of PSA. So if you do PSA, I think airway management is something complementary to that. And actually, talking about the traditional specialties pulling away from the ED, the leadership of the anesthesia clinic was actually expressing need for our contribution. So they really thought that they'd like to use their people working in the operating theaters and in the ICU instead of allocating someone to the emergency department. So how did we start? We, of course, went through discussions amongst ourselves, our team, to make sure that we all share the same vision and are prepared to take the steps that are needed to get there. Then, in the hospital environment, there are a lot of politics. I don't know about Sweden or Norway or Denmark, but in Finland it's a lot of politics. A lot of different kind of relations, PR, and personal relations as well. So I think in our very traditional, very slow-moving university hospital, a lot of sort of toes to step on. I felt that it was important to build personal relations to the key players in the system. Among anesthesia in the ICU. So I had these chit-chats and talked about, had a cup of coffee, sort of things. And tried to find allies, because there are allies to be found that see the purpose in this. Of course, you don't want to ambush anyone, or you don't want to hide things. It should be open, and it's important to keep people informed what we are trying to do, what's our goal. So in the beginning, I think it was for us important to have sort of a couple, or maybe one person, a pioneer, to begin doing it. So I think that person has to be quite accomplished. The person has to have the skill set, the confidence to perform, humble enough. So you don't want to create too much aggression, but again, decisive enough to own the situation. So we started piloting quite early, and actually I was the first one to do the anesthesia shifts. And where did I get my skill set? You see that I'm an old guy. So when I was a young doctor, there wasn't any emergency medicine training, of course, in Finland. So my path has been quite different, but I've learned or collected, built the skill set by working in the operation theaters, working in anesthesia, working on ICU, and so on. So I felt that I'm confident in doing this. Then really early on, we had this sort of rudimental SOP, standard operating procedure. We wanted to standardize and develop it to be better. We made a strategic choice to do that in cooperation with the anesthesia clinic and the ICU, because I thought that it feels safer for them to be involved and to have an opportunity to say what they thought about things, and at the same time making sure and clear that it's our standard operating procedure, so it's owned by us, the emergency department. Involving nursing team, of course, is important and essential, building in instructions and operating procedures. Then building the physician team capable of doing this. Of course, as I said, we didn't have as many specialists then, and this whole journey has been also of like developing emergency medicine existence or emergency medicine in our hospital. So we have recruited a lot and trying to find people that are already have a good skill set or have a great potential and to learn and want to learn. Then again, the people already working with us needed maybe refreshing of their skills. We had to arrange learning opportunities, in-house training, again in cooperation with the anesthesia people. External courses, whatever you can think of. And of course, the thing that we are doing more and more, and I find really important, is having discussion among the team and sort of finding our ways of doing things, our standards, and writing them down as well. But it has to be it has to start from the discussions amongst the team, sharing the knowledge, learning from your peers. And of course, hugely important when we are starting a new way of doing things, offering support and guidance to the people doing it. Someone mentioned that the worry often is patient safety. Is this safe? And of course, quality and patient safety is an assurance of them is hugely important because this is high risk procedure. So we wanted to make sure that we have this additional support in difficult clinical scenarios, or at any moment the physician in charge feels that he needs support. So again, in our place, with really vast resources, we have access to that. So it might be one of us, more experienced emergency physicians nearby. It might be the doctor working in our intermediate care unit, or it might be a senior anesthesiologist from the operating theatre. It might be an ICU doctor, but we have a low threshold and easy access to help. In the beginning, I felt that it was extremely important to proactively seek feedback. I don't know about your cultures, but in Finnish culture, it's really, really difficult to give feedback or get feedback. So it happens behind your back, not in front of you. So I sort of sniffed around and asked a lot of questions of different people, of the anesthesia people, of the ICU people, of our nurses, who have eyes and ears everywhere. So if something goes wrong, our nurses know it. So you have to be proactive in getting that feedback, and of course, giving it. You have to be better. That's something I have to learn a lot. I've learned a lot of giving feedback. It gets easier, but it's difficult, of course. After shift reviews, M&Ms, so on. We already also talked about this, like integrating learning into everyday life. We have also found that very useful. So we work as a team every day, so that is practice, of course. But then we have integrated this in situ, or like we call them mini simulations, into the everyday life. We can go through the for example, intubation standard operating procedure with our nurses now and then. When you're starting a new way of, or new function, or new way of doing things, you have to be prepared to take a little bit of extra responsibility. So it's not like that my shift is actually, it's ending in 2 minutes maybe. Bye-bye. It's taking that one extra step so to get the job done. In our case, it might have been covering for a sick colleague, or doing something extra. So to show that we really we are responsible for our shifts, and if there's a emergency physician colleague who gets sick, can't take care of the shift, we will take care of it anyway. It doesn't end up so that the anesthesia people have to cover for us, for example. Be extra careful. Then you have to tolerate a bit of being under microscope. that's inevitable, I think. If you start doing something new, there will be people watching you extra carefully. You have to be extra careful to perform. And that's the way to build trust. Performing and meeting the standards. So if you meet the standards, if you perform, in a while, there won't be a problem. And then it's also important to recognize that the change, it's a huge thing. So it doesn't happen overnight, and you can't have it ready in 2 days or 2 years. So the change is going to be gradual. There is going to be sort of 2 different systems coexisting, 2 different ways of doing things, and it will gradually change. And it might be that like at some level, the systems will coexist for a long period of time. So, just that was about our journey, or some insights that I might have gained. Hopefully useful for you as well. This remaining time, I can sort of go through our standard operation procedure, SOP, and hopefully then we'll have time to discussion as well. So we have this large, or quite large document, sort of a general document for airway management that describes our way of doing it. It's written down. Then we have a separate checklist, pre-intubation checklist. And then we even have, more for training purposes, something we call role description cards. So there's a separate card for every person in the team taking care of the airway management. So there's one for intubating physician who's in charge, and you can read, or he or she can read what are his or her responsibilities in the situation. There's a card for nurse assisting in the intubation, for nurse responsible for the medication, for the nurse responsible for documentation and keeping eye on the vital signs and the monitors and so on, and even a separate card for person doing the manual inline stabilization if it's needed. So to make it simple enough, we have these airway cards here and there in the emergency department, and they are all the same. Absolutely identical, and to be sure, we all also have printouts of our standard operating procedures and the cards, role description cards as well in the cards. Our goal is RSI. We do modify, so we do a bit of delayed sequence intubation. We sometimes have to ventilate the patient and so on. We use as a standard video laryngoscopy and a bougie. There's an option to use a rigid stylet according to physician preference. We have a video scope readily available as well, and the normal drill with the reserve or plan Bs and emergency surgical airways. As simple as possible, what comes to the instrumentation in the surgical airway. Medication. We have decided to have a set list of medication that is drawn every time. If I say I want the medication drawn according to the SOP, this is what I get. Then I can, of course, say I won't need ketamine this time, you don't have to draw it. Or if we go ketamine only, then I will let the propofol. Then we have push dose vasoactive at the moment, phenylephrine, and or the nurse is set up for infusions as well. So we have noradrenaline and propofol infusions standing by. Something we have to, or something we haven't done, we haven't get there yet, is a checklist, post-intubation checklist. That's something we want to have. The post-intubation care otherwise is described in the general SOP. We have only two types of ventilators in the ICU, and the simple basic modes, so nothing really fancy. Experiences this far, we haven't had any adverse events related to emergency physician performed intubations. The emergency physician team is happy, I hope, I hear, and keen to develop their expertise. We've really got great teaching and learning opportunities for our trainees. So I think we are preparing them to be a better emergency physicians. They have a better skill set than we used to have. Our nursing team has spontaneously given feedback that it's so much nicer to deal with the critically ill patients and airway management with our own doctors. They are much more comfortable, they perform better, it's smoother, and I think that's quality. The adherence to standard operating procedure is good, so I think that's a big difference if we think of the starting point where there was no adherence or it was poor. And we have maintained generally a good cooperation with the anesthesia and the ICU colleagues. So future goals, it's always, these electronic medical records, they claim to have every this and that, but it's really hard to get data out of them. So I wanted to present you data about our intubations. Just real numbers, it's some intubations every week, so roughly one a day. But I didn't get it out of the system. But I'd like to have some quality metrics. There's some variation in documentation that I think we have to get rid of. I've started thinking of saving all the video laryngoscopy views for learning purposes. That's something we have to discuss with the team. And of course, we want to continue developing these house rules and SOPs and our ways of doing things in the field of critically ill patients in the ED. With this, I thank you. This is, again, a picture from my home base, and this is part of our happy team på Meilahti. Thank you. Tack så mycket. Please. Oh, yeah, sure. I won't throw it. I won't throw it.
Just one question.
Yeah.
Like, at what point do you involve the anesthesiologist?
Yeah.
Like, if you have like someone with respiratory failure, you intubate and then call them and like, can we come to the ICU now?
Yeah.
How does it work?
Yeah. So,
Nice.
so we do it. Yeah. And of course, if we even think of, suspect a difficult scenario, a difficult airway, we want to have more hands. So it might be one of us, so more experienced, or the most experienced emergency physician, or it might be the ICU doctor that we ask to come for help. But the routine airways we do ourselves. Yeah.
So thank you. Great talk. Very interesting. I'm jealous. Just to understand the context a little bit more, I work in Malmö, and we cover almost as much as we can cover, and we're growing broadly, like in a lot of fields. Do I understand you correctly that you're not fully covering the ED, and you still have a lot of other specialties working in-house? So you have been working like this is still the advent of emergency physician-led emergency department, and you've been able to focus more on the critically ill patients early. Do I understand it? Like, that's the trajectory.
Yeah, I think in our place, which is really a ivory tower, so I think there will be some coexistence in the emergency department a long period of time. So there will be doctors coming to do shifts and work, or do rotations in the ED from other clinics. But I think it's the advent. If I understood you correctly, you asked if it's the advent of emergency medicine that has helped us to get there, get here. Or I think so. Yeah.
So how much of like all of the shifts in the emergency department does your emergency physicians cover? Is it the majority, or?
It's not half and half.
Okay, so you've been able to like allocate and like do this focus.
Yeah. Focus on the critical.
Okay.
Yeah.
Thank you.
I think we are over time, but that's the last question.
My question is a yes or no answer to. Did I understand you right that you had in your intermediate care unit patients treated intubated?
Yes.
Yes. So you don't always have to agree with the ICU.
No, because we have our own unit. Absolutely.
Yes, and I think that is a success story.
Yeah, and that's a really big asset. Yeah. Thank you. Tack så mycket.